tell a story about where we're at about surgery in kidney cancer. And as Nick mentioned, I was Judy's doctor. I've known Nick for 10 years. I fully understand the importance of societies like this, and I'll show you why in a little bit. Before I start, I want to clarify what the talk's about. There's no doubt that the gold standard therapy for kidney cancer or kidney tumors is thermal ablation of the cancer or removal of the cancer. That is the gold standard. There's no doubt about that. That's not going to change. What we're talking about right now is metastatic kidney cancer that's spread. So what do we offer surgery-wise and when and how? And some of this has been in the news recently, and we'll talk about that. So what do we mean by surgery for metastatic kidney cancer? What we mean by that is one of two things. Number one, taking your kidney out. Should we take your kidney out when the cancer spread? Is there benefit to that? When should we do it? And so on. The second type of surgery is if the kidney cancer spread, either before we take your kidney out or after, should we take out the spread? So if the cancer spread to your liver, if it spread to your lymph node, if it spread to the lung, should we take out that tumor? So these are two different things. So removing the kidney or removing the actual tumor that's spread. The principle does this date back to the earliest days of surgery. When you look at, say, Halsted, one of the pioneers of surgery itself, they figured out that even in metastatic breast cancer, patients did better with the breast out than with it in. And you'll see this in numerous portions of the literature. Colorectal cancer, ovarian cancer, melanoma, sarcoma, etc. A lot of cancers, if the tumor's out or debulked, the patients do better. It's important for us who take care of kidney cancer because 30% of the patients that present with kidney cancer or have had treatment for kidney cancer either have or will develop metastatic disease in the future. And as all of you with kidney cancer or who treat it know, there is no more, or this is one of the most chemo-resistant and radio-resistant tumors. So, how does the story start? The story starts, since it's chemo-resistant and radio-resistant, as Nick said in his talk, we kind of went into the cytokine era, which is interleukin, interferon. When I was a resident, patients have metastatic kidney cancer. Winston would put them in the unit, just like you guys did at Indiana. Patients got sick. It was tough stuff, and it didn't work that well. So then we said, okay, there were two good randomized trials in the early 2000s. What if we take people's kidney out before we give them interferon, interleukin, and so on? And what we found was that patients tended to do better with their kidney out than with it in. They felt better, did better, lived a little longer if they had their kidney out and then got this therapy than if they just got the therapy up front. So I'll tell you, I make the argument right there that the cytoreductive nephrectomy era was born. Some overlooked factors, though, were that, number one, the patients who did the best came in looking the best. And what we kind of say to patients, our residents, and so on, the sicker the patient looks when they come in. If they're in wheelchairs, they can't get out of bed, and so on, they're not going to do good no matter what they do. Where if they come in walking, talking, eating, haven't lost weight, they're going to do better. But as with every study we see in medicine, everything gets extrapolated. So what we... okay. Oh, for the video. All right. So as with everything in medicine, when we start to see studies, we start to push the limits. And then it became pretty much in the mid-2000s, everybody with metastatic kidney cancer came in and had to have their kidney out. And Julio probably remembers this. No matter how bad the cancer was, oncologists, anyone would say, hey, here you go, take this kidney out. And we didn't do that well with it. People could die. We had high complication rates, blood transfusions, and so on. We were seeing things like this. Now, this isn't just a big tumor, but to me the most concerning thing would be the lymph nodes around the hilum, which make this difficult to remove. You've heard of people bleeding to death during kidney surgery. It's a bloody surgery. Well, I make the argument a lot of this is access to the renal hilum or the artery and vein of the kidney. So we would see patients like this with big lymph nodes around the renal artery and vein, big tumors, and they just didn't do that well after surgery. So we kind of pushed the limits on taking kidneys out in people with metastatic kidney cancer. But also overlooked is no matter what we did, patients just didn't do that well. So luckily there's a new event. And what we've learned in a basic sense is that kidney cancers get big because they produce their own blood vessels, so to say. So if we can inhibit that, stop the cancer from making its own blood vessels and blood supply, you could shrink the tumor and patients did better. And we kind of ran into this era, or we are in this era, of anti-VEGF drugs, TKI drugs, we use the Sutent, sorafenib, mTOR inhibitors, etc. The good news is most of these were oral pills, so we didn't have to admit them to the ICU. They had a lower side effect profile, and they tend to work a little better, especially in the metastatic tumors. Never impressed with the results on the kidney tumor itself, but we did see shrinkage of the metastatic tumors, and patients did well. So what we did was take these studies from the interferon interleukin era and said, hey, the patients did better with their kidney out, and we extrapolated it to these drugs. And we basically took that SWOG, EORTC studies and said, hey, if they did better with interleukin interferon, they're certainly going to do better with their kidney out in these drugs. So we extrapolated that data, and what we see in most observational studies, when you take all these observational studies, and especially recent ones, and analyze them, again, patients who have their kidney out do better than patients who have their kidney in who are getting systemic therapy. Now, these are observational studies. There is one randomized controlled trial that's been in the news recently, and we'll talk about that coming up in a minute. But what's overlooked still, yes, these drugs did better, survival was better, but it's still not that good for some of you in the audience who have taken this stuff. The median survival, 24 months or so. And most of the studies that were done on these drugs were done on patients that already had their kidney out already. So we still weren't sure, should we be taking the kidneys out or not? And we also overlooked is a percent of the patients who we take these kidneys out, as Julio knows from back in the day, never even got to get the therapy because they did so bad during surgery. Either they had a bad complication or their performance status was so bad, they never even got a chance to get systemic therapy. So how do we solve a lot of these things, or try to solve a lot of these things in medicine? Is we try to do randomized controlled trials, which simply put is we bring you in, blind you to what you get, we flip a coin and say half you go one way, half go the other, and we're going to see which way does better. It's hard to do, and I'll explain why in a minute, but this is the Carmina trial that's been in the news recently. Not only in our medical literature, not only with our referring physicians and our primary care doctors and oncologists, but also on the actual news. And basically what they did was they randomized patients with metastatic kidney cancer to either get your kidney out, followed by therapy, followed by Sutent, or just do Sutent and see who does better. But it really wasn't to see who does better. It was just to prove that Sutent was equal to getting your kidney out, okay? So what we saw when you look at progression-free survival or overall survival is that the Sutent patients did just as good as the patients who had their kidney out and got Sutent, which led to the conclusion, should we be even taking kidneys out at all? And in fact, when this was presented, one of our oncologists called and said, hey, we probably shouldn't be taking kidneys out anymore. And I'm like, well, I'm not quite sure that this study shows that. So that's led to a lot of examination into this trial to see exactly what does it really show us. First off, what we'll say is over an 8-year period in this multi-institutional study, you only got 450 patients. The main reason you got that is because the patients that could tolerate surgery and did well from surgery went to surgery. So this wasn't every single comer. This was patients they chose to be in the trial. Well, what that did was select for sicker, less well-off patients. So right away, you can see they had a hard time enrolling patients because if you came in and your kidney could come out, it came out. So what we really saw in the trial really wasn't what we see in everyday life. 17% of the patients who got the Sutent-only trial ended up getting their kidney out. Now, a lot of people would say, oh, yeah, they had emergent bleeding, but only 8 of them were for bleeding. 30 of them responded so well to the drug, they ended up going on and they were in the trial, and either their oncologist or urologist said, hey, you're doing so well, now it's time for you to get your kidney out. And this was a pretty sick group of patients. When you look at volume of disease, the volume of disease was higher in the metastatic sites than it was in the kidney sites. So what you really ended up was a trial that included intermediate poor risk patients who, like I mentioned before, don't tend to do that well no matter what you do. And also missing from this is, what does the patient want? How does the patient feel? How are they with the distress of not having surgery? And we'll talk about that in a second. So in essence, Carmina does not support not taking kidneys out. What it does support is being a little more selective, or a lot more selective, on who you do take kidneys out of. Overlooked around the same time was another trial, CERTIME trial, which is a little more practical, which is basically saying, okay, if you have metastatic kidney cancer, you can either get your kidney out and get the systemic therapy, or what if we put you on systemic therapy, see how you do, and then take your kidney out, which is a little more practical way of looking at it. Same type of setup as the Carmina trial, again, enrollment problems because of what I mentioned before. If your kidney could come out, we went and took it out. So, but the conclusion of this is if you deferred the surgery with systemic therapy, there was really no harm in that. So perhaps in patients with bad metastatic kidney cancer, we don't lose anything by putting them on systemic therapy, seeing how they do, and then taking the kidney out. This is a good survey that came out of the K-Cure Alliance that basically took the hype from the Carmina trial and so on, presented it to patients and said, okay, if we told you the data from this trial, would you still want your kidney out? And you see here, 3/4 of the patients still said, yeah, I want my kidney out. I want the root of the evil gone. And there were some psychological reasons for this. There was the source of primary disease being removed. Also interesting in this, when you look at it, it's on the internet, is the despair of being told that you're not a surgical candidate. And I think that that's one of the psychological things that gets overlooked is, hey, we can't do surgery. Well, that's different than telling people, hey, why don't you go on systemic therapy and then we'll reevaluate surgery. So there's a lot of psychology there for us as treating physicians. And the last thing, and oncologists know this better than anybody, the hardest thing is to do something and the patient has the perception that either you don't know what to do or you've given up. Luckily, we had a new thing going on, and that's where we know that your body fights off cancer, okay? Your body's immune system does. In simple terms, that I can speak on, our oncologists in the group know a lot more about this than anybody. We learned that cancer itself has learned to turn off the immune system response to the cancer. That's why it can run free throughout your body. So what if we turn off the thing that's turning off the immune system? And there's a series of drugs that do that. And perhaps we could even block that pathway, and that's where you hear on the news the PD-L1 pathways, PD-1 pathways, and so on. But what if we take two different sites that do that and turn them off? Can your immune system be reactivated to kill cancer and fight cancer? And our oncologists saw a lot of success in lymphoma, melanoma, and so on with these type of drugs. So when you look at drugs like, as you see in the news, nivolumab, they're blocking the immune system blockage of the tumor. So they're reactivating your immune system to fight the tumors. Well, guess what? It tend to work pretty well. When you take patients with metastatic kidney cancer, and this the Checkmate trial, it also was some in the news, what you saw was when you compare these drugs to the standard Sutent in terms of how you do with metastatic kidney cancer, the patients who were on the nivolumab combination did better than the patients on the Sutent. So perhaps we're in a new era. But I'll tell you anecdotally, we're seeing things we never saw before in kidney cancer. I can tell you right now, this is a patient who came in a wheelchair, losing weight, could hardly eat. And you see a big tumor. Now, is this resectable? Yes, it is, but it's a big tumor, and he doesn't look good. He's in a wheelchair, he can't eat, he's only 38. So we do nivolumab, and what do we see? Look at this, is extraordinary. These are things we never have seen before. So this is the same patient. This is an x-ray 6 months later. I think Winston actually was taking care of this one. Look how small the tumor's gotten. Now we've gone from, and the patient's not in a wheelchair anymore, he's eating, he's gaining weight. So this goes to our, perhaps you should be getting systemic therapy first. Let's evaluate how you do, and then take your kidney out. And I make the argument, we take this kidney out, the patient does very well. Now some people raise the concern, well, what happens when you give these drugs and then do surgery? And we just had a paper that came out of Mayo Clinic, Florida. We took numerous patients that had these type of drugs, not just kidney cancer, but various types of other cancers, and did surgery, and their outcomes are no different than patients who never had the drug. So the drug itself is not making the surgery worse. Again, we're seeing things we've never seen before. We're seeing patients that have tumors. This is a tumor recurrence in a very difficult location to resect. With systemic therapy now, it's gone. And these are things early on in my career I never saw. So perhaps we're entering, or we have entered, a new first-line therapy as compared to the Sutent and so on. The problem with everything in medicine that works, somebody's got to pay for it. And you'll see a lot of this when you search these drugs on the internet. I was just talking about it with our Pfizer representative back there. These things are a minimum of $100,000 a year to give. So who's going to pay for that long term? We've already seen in England that they've already pretty much declared they're not going to use the drug. So if you want to get it, you either have to pay yourself or come to the United States to get it, but they won't be paying for it. So we do have these drugs that are making advancements, but they're expensive. And this is nothing that you haven't heard. So bottom line on taking your kidney out with metastatic kidney cancer or cytoreductive nephrectomy is I think we've entered a new era. No longer do we just have to see patients with metastatic kidney cancer. And everyone, at least where I work, and I'm sure Indiana, the various other University of Florida, we've seen now a better thought process into going out, okay, whose kid, we know that your best chance for long-term survival and doing well is with your kidney out. And we can start to look at you now and say, okay, you know what? I think we're going to take your kidney out. I think we're going to put you on therapy and see how you do and so on. We become much more selective. As a result, our operative outcomes are getting better and patients are doing better. So we're reaching a different group of patients now, which is A, just take your kidney out right away if we can. If you look like if you look good and the tumor looks like it'll come out, let's take it out. Or we reach another group where we say, hey, you know what? You're a little questionable. Let's put you on systemic therapy and then take your kidney out if you respond and do well. And then the last one, which is our toughest patient, is bulky, awful disease. Well, let's put you on some of these drugs. Let's have hope that you improve, that you can become resectable and do better and go from there. Last thing I want to talk about, patients that have had their kidney out but show up a few years later with recurrences, okay? What to do with those? Should we put them on systemic therapy? Should we watch them? Or should we go do surgery? This is another example right here. This is actually in the lung. So this black is lung. So this is a patient doing very well, also in his 40s. Had his kidney out previously. 5-6 years later, you get a lymph node recurrence. What should we do with those? What I'm going to tell you is overwhelmingly, and I think everyone knows this, there's good Mayo data on this in multiple centers that say if the patient has recurrence or metastatic disease that spreads somewhere else, they do much better with that removed than they do on systemic therapy or keeping it in. And again, another meta-analysis, again, most of these are observational trials. And I think most of our oncologists and other physicians would agree, if the tumor can come out, we take it out, and they do better. So as far as taking metastatic lesions out, as long as we feel like we can get everything out, we do. Last point on this is complex. The patients are complex. It's a complex topic. The drugs are complex. The surgery is complex. And there's more and more data on this that's out there. But basically what this is saying is, if you look at your practice or your tertiary referral center, University of Florida, Mayo, Indiana, and so on, the bottom line on this is this topic is becoming so complex, and it's not just kidney cancer. You see it in every field. The more your group does or the more your practice does, the better the patients do. So we're getting into the era of metastatic cancer where you can't just go out and have a doctor here, and so on. What you're starting to see, and if you're a patient, you're much better off in a kidney cancer program than you are being taken care of just a group of doctors. You want people who do this all the time. You want your Winston Tans talking to them. You want your oncologists who know the exact steps. You want the relationship between the surgeons and the oncologist and radiation oncologist. Okay, here's what Thiel's going to want to do. Here's what Winston's going to want to do, and so on. So that's an overview and a simplistic way of surgery and metastatic kidney cancer. On Nick's point, I do want to point out that when you look at our major cancers that gather a lot of media attention, kidney cancer is the highest in terms of average years of life lost. But the dichotomy here is when you look at that, we're still one of the lowest ones, especially when you look at breast cancer, prostate cancer, colon cancer, lung cancer. The funding for kidney cancer lags behind those cancers, and that's why I think, Nick, your initiative with Judy Nicholson on educating, not only the patients, not only the providers, but more importantly, the people who pay for these type of trials and so on. It's very important that we keep up in this realm, because as you see, we're making inroads, but we're still not doing that well. So we're doing better, but it's not perfect. So I appreciate you allowing me to talk. Anybody that has any questions, feel free to let me know.